3, 2, 1. Three, two, one.
Good evening, everyone. A very warm welcome to all our SADA members. I am Dr. JP van Zyl, and it's my honor to welcome you all to the first SADA Algoa Midlands CPD meeting for 2021. Wishing all our members a blessed and a prosperous new year. 2020 was without a doubt a challenging year with several changes and adaptations to the new normal. But with good planning and strategic practice management, I trust we can only go from strength to strength in 2021. Firstly, I would like to thank SADA for the assistance and support for hosting virtual CPD events to keep us connected as proud members of SADA. Kindly note, for now, all CPD events will be hosted virtually, but we hope and look forward to the day that we will be able to reunite. A special thanks to you, Marlies Jansen van Rensburg, and a wonderful team from SADA head office for organizing and ensuring our virtual sessions run smoothly. We appreciate all your effort in this regard. There's a few house rules for tonight. Please refrain from using the raised hand button at the bottom, but please feel free to leave all your questions in the questions section as we will address them at the end of the presentation. CPD certificates will be loaded to the SADA platform, and you will be able to access all your certificates under your member profile. If you are not a SADA member, you will be able to create a profile for yourself to access your CPD certificates. Very important, during tonight's presentation, there will be polls running throughout the presentation. Please participate in these polls, as this will grant you the one CPD clinical point that will be up for grabs tonight. We are streaming live on YouTube tonight as well. So if you have any problems with your Zoom, please feel free to log on to our YouTube channel. There's also a reminder that afterwards, after the presentation, there will be an evaluation. So please stay put to evaluate the presentation afterwards. There's a few upcoming events in February. And just to inform you about that, on the 4th of February, we have Dr. Darren Green that will be speaking about lockdown and the social brain. And on the 11th of February, we have Dr. Dawie Sleebush speaking about snoring, sleep disorders and breathing, and the dentist, a practical guide. Now, without further ado, I'm going to give over to my colleague, Dr. Asmal, to introduce tonight's speaker for us. To you, Dr. Asmal. Thank you.
Thank you, Dr. van Zyl. My name is Dr. Asmal, and welcome everybody to today's webinar. I've been given the mammoth task of introducing our speaker for today, Dr. Neil Barnard. When I saw this CV emailed to me, I was thinking to myself, what have I achieved in life? And I'll be happy to let you know I didn't spill my coffee today, so that's my achievements. So let's get through to Dr. Neil Barnard's credentials. Let's start from the top. Basically, so firstly, his qualifications. In 2006, he graduated with his BChD from the University of Cape Town in Stellenbosch. In 2013, he qualified with his MBChB from Stellenbosch University. And in 2019, he qualified with his MDS in Maxillo-Facial and Oral Surgery, cum laude, from the University of Western Cape. As far as his work experience is concerned, in 2007, he did his community service in the Maxillo-Facial and Oral Surgery Department at Livingstone in Port Elizabeth, represent. In 2008 to 2013, he was in private dental practice, that's in Somerset West. And then I take it he got tired of private practice. And then 2008 to 2013, he was a medical student. In 2014, he then did his community service for his medical degree in Port Shepstone Regional Hospital in KZN. Then from 2015 to 2019, he was a full-time registrar at the MaxFac department in the University of Western Cape, being Tygerberg Hospital, Grootte and Redcross Hospital. And then from 2020 to 2021, he has been in private practice at the Louis Leipoldt Hospital in Cape Town. and has been a senior lecturer in the Department of MaxFac in UWC. As far as skills courses are concerned, in 2014, he did the Advanced Trauma Life Support and Pain Management Workshop, 2015, Microvascular Surgery Cadaver Workshop, Orthognathic Surgery Cadaver Masterclass, Southern Implant Course, the AOCMF Principles in Craniomaxillofacial Fracture Management, 2016, the AOCMF Gunshot Injuries Course, Facial Aesthetics Course, Flap Procedures Course. And thereafter, you thought that was all? No, there's still more. Then you, as well, in addition to that, from 2009 to 2011, he was anatomy lecturer. And then from 2015 to 2019, he has been giving lectures to various academic specialities, including ENT, ophthalmology, emergency medicine seminars at the MaxFac department. And then from 2019 to 2021, he has been doing his MDS maxillofacial surgery thesis. Quite amazing credentials there, and we are all really looking forward to today's topic, and all the best to you. And please, everybody, leave your questions in the Q&A section, and I'm going to hand over to Dr. Niel Barnard now.
Okay, thank you very much. Yessie, perhaps I shouldn't have sent such a long CV. I've actually put myself now up for a lot of stress and a lot of things that I have to now live up to. So let's get the lecture started. Let me just open my screen here. Let's go to slideshow. Everybody, your sharing screen. For some reason, are you guys able to see my slide here? Let's say slideshow. Everybody share any? Doesn't want to share. Are you guys seeing this? New share. Slideshow. Doesn't want to share the screen. Slideshow. Just a sec. Some technical difficulties.
I think just maybe stop your screen share and then try and start the slideshow and then share your screen.
Okay, let's go again. Start from the first. There we go.
There we go. Perfect.
Can you all see it?
Yes.
Yes.
Okay, great. Okay, so after those little gremlins, we are ready to begin. This talk that was set forward by the Algoa Midlands, that they requested me to talk a bit about medical emergencies in the dental practice. So you all know who I am. I'm Neil Barnard, and I just want to thank you for giving me the opportunity to speak to all you guys out there. And I hope at the end of this, you guys will be a little bit more informed about what can happen in private practice regarding medical emergencies. So this is just a little bit about myself. This is where I work. These are the various hospitals that I run in between during the day. That one there at the left top is the University of Western Cape's main campus. That is at Tygerberg Hospital. Then there at the bottom left is Grootte Schuur Hospital. At the moment, I'm spending a lot of time there teaching registrars. We've just taken in a new batch of registrars, so they're keeping me very busy at the moment. And then somehow I still have time there at the top right, mostly after hours, to do a little bit of private work at Louis Leipoldt Hospital, and then also have a foot in the private field, which really helps regarding the more intricate, more expensive procedures, since we do struggle a bit in the state. And then there's Redcross Hospital as well, where we are also involved with helping a lot of children. I'm just going to say now the outline of the talk, so to just guys know what I'm going to be talking about, is that We are basically going to look at what the situation is in South Africa. We're going to see which medical emergencies are seen in South Africa. And then we're just going to talk a bit about these various emergencies, just discuss them a bit. And we are going to look at what is reasonable for a dental practice to be prepared regarding a medical emergency. And then we're just going to look a bit and see what kind of stock you need to have in your practice to be able to manage medical emergencies. And then there'll also be some algorithms to know just in case you get confronted with an emergency. Lastly, we're going to look at what dentists actually keep on their trolleys to be able to manage medical emergencies. This is now from a study that was published in the South African Dental Journal. Right, let's get started. Okay, so this is the study that I was talking about. This was published from researchers in WITS. The researchers is Quinn and Misra, and they basically sent a lot of emails to a lot of dentists. 267 of these dentists responded, and they were asked how many medical emergencies they had to treat over a one-year period. Like I said, they sent out a lot of emails. 267 dentists got back to them, and the results were that 90% of respondents had encountered at least one medical emergency, whilst 44% in that year didn't encounter a single medical emergency, and 37%, that's 98 dentists, had experienced multiple emergencies over a one-year period. It's a bit difficult to say something about these results because not all practices are equally busy. There are practices that see 30 patients a day, and then there are practices that see 2 patients a day. So it's very difficult to say exactly how large the occurrence is of medical emergencies. Over the years, I've had to manage quite a few medical emergencies, but I mean, that's in a big tertiary hospital. It's in a dental school where the students see a lot of patients per day. And at a stage at Tygerberg, there was at least one medical emergency, I would say, every week almost. And maybe have been something like a vasovagal to more serious seizures. We've had hypertensive urgencies. So the take-home message is these things do happen. And it's advisable that we are just prepared to be able to manage these emergencies. Okay, this also said, this was the recommendation from the WITS researchers, is that they said, as there is no South African list of recommended equipment and drugs, this should be developed and regularly revised, most suitably by the South African Dental Association. So this is perhaps something that we have to look at. It's advisable that we do perhaps start getting a policy about what equipment should be in a dental surgery to be able to manage a medical emergency. Okay, and this is then the emergencies that do occur. You can just have a look at this list. Right there at the top is something we all know. It's a vasovagal syncope, the common faint. We inject local anesthetic on a daily basis, and obviously there are people that react negatively towards local anesthetic. Other things, anaphylaxis, which is a lot more serious. Luckily, none of those dentists ever had a myocardial infarction, but there were some strokes, cardiac arrests, chest pains, asthma attacks, diabetic comas. So these things do happen, and this is just from those respondents that responded to the questionnaire. So in the next few slides, I'll just go through some of these conditions, just to give a broad idea what the conditions are about. Yeah, the first one is the vasovagal syncope. As you can see there, there's a picture of the vagus nerve, and the vagus nerve is the whole culprit of what causes the vasovagal syncope, also known as the common faint. So it's basically an anxious patient that arrives at your surgery, and then the whole time he's in sympathetic overdrive. The sympathetic nervous system is firing, and then the vagus nerve, which is a parasympathetic nerve, takes over, and the patient develops a bradycardia and a hypertension, and the patient faints. I'm sure a lot of the people listening to this talk have encountered patients fainting in the dental office. Then also something that I've encountered a lot is patients with seizures. Seizure patients are not necessarily epileptics. You can develop seizure disorders from a lot of other reasons, most common being hyperglycemia, electrolyte disturbances, and especially us working with facial trauma, we see a lot of people that had post-traumatic brain injuries that now develop seizure disorders. So this is another occurrence and something to be cognitive about, and something to be prepared with on your emergency trolley in case someone does seize in your rooms. Then also allergic reactions. The reactions can vary. First, you need to be sensitized. You need to, it's an IgE mediated response where you have priming of mast cells. As you can see there on that picture, the antigen needs to cross-link with 2 IgE antibodies on the mast cell to be able to release the histamine. And then, yeah, the patient will get a rash, can have a bronchospasm. The bottom one there is swelling of the eyes. So yeah, these are conditions that can happen in any dental surgery, really. My final year question as a student intern was, I had to explain how you put up a chest drain. And I explained to the professor exactly how you put up the chest drain. And he said, okay, you've put up the chest drain now. Now the patient can't breathe. What is wrong? I had no idea what the correct answer was. And then he told me the patient had an anaphylactic reaction to the lignocaine you gave. And that's why the patient died. And I told him, you see, I'm a dentist and I've been injecting lignocaine for a very long time. And I've never, ever in my life encountered any allergic reaction to lignocaine. I didn't believe him. And then I asked around, and one of my friends that was working in a casualty said, yeah, just a week ago, he had a patient that he had to suture, and the patient developed an anaphylactic reaction to lignocaine. So I read up, it's very rare, less than 1%. But if a patient does tell you they are allergic to lignocaine, a good alternative is then to use bupivacaine instead of this. Moving on to the next slide. This is the occurrence that no one reported, myocardial infarctions, but there were a few of anginas. So myocardial infarctions, you can diagnose with an ECG, basically ST elevation or non-ST elevation, myocardial infarctions, the so-called NSTEMIs or STEMIs. And the only real way to know if someone had a heart attack is to look at the cardiac enzymes. So you basically do a troponin and you see if there is any cardiac enzymes. Now, any patient developing chest pain in your surgery, don't immediately think that this patient is having a heart attack or having angina. There's an extremely long list of causes of chest pain. You can get a costochondritis. It can be a pleuritic chest pain. If I had to tell you how many times I worked in a casualty and someone came in with chest pain due to gastroesophageal reflux. We are putting patients flat, supine, and if that patient has a diaphragmatic hernia, good chance that they may have some reflux, and that is known as heartburn. So there's lots of reasons for people to get chest pain. If someone is actually having a heart attack, you will know that they are having a heart attack. It's angina pain is described as a severe pressing pain radiating to the left arm, and it's usually associated with nausea and vomiting. So usually if someone has a heart attack, you'll know they're having a heart attack. And then the best thing to do, we'll go a bit through the treatment later, but these days they need to be taken to a unit where cardiologists are available, where that's the bottom picture, where they do PCI, percutaneous interventions, to relieve that obstruction. Okay, let's go to the next condition. The very common asthma. I myself was an asthma sufferer, and the two pumps that you use is your relievers and your preventers. Your relievers is then usually something like the Ventolin pump that's got salbutamol in it, and your steroid pumps. And asthma is a form of atopy, so it's an allergic reaction that causes bronchospasm, and it's usually in children. The best thing, if you are seeing someone with asthma, ask them how often do they need to use their relievers. That'll give you a very good idea about how severe their asthma is. And if they tell you they get asthma attacks almost every second or third day, just the asthma is. Okay, next condition is the stroke. That's a very serious condition. If someone gets a stroke in your surgery, the only way to really, it's difficult to recognize. Usually these patients present with something termed a TIA, transient ischemic attacks, that they've complained about previously. They usually complain that they experience numbness in the extremities, blurry vision or slurred speech, and obviously these patients need to get to an emergency unit as quickly as possible. Okay. Then also something that kills very quickly is low blood sugar. High blood sugar can't kill you. There's a lot of type 2 diabetics out there on the streets with sugars that are sky high, that only gets diagnosed as diabetics quite a long way along the line. But I can promise you there aren't many people walking around with sugars of 1 that are still alive. So your brain needs glucose to be able to function. Hypoglycemia can kill very quickly, and especially if you're doing a long procedure, or even if you're doing, let's say, a sedation, that patient is not eating in that time. And if they started off with a low blood sugar, then you have a problem, and you should have a good, hopefully you've got a good anesthesiologist with you that can then just supplement the glucose. So these patients, if they are awake, actually present with sweating, confusion, anxiety. As I've mentioned previously, you can also have a seizure if you have a very low blood glucose. So this is something to consider. Also, some of the insulins that are long-acting, these patients need to be able to snack intermittently. Otherwise, the insulin will bring their blood sugar much too low, and this can also be very, very dangerous. It's not a bad idea to have a glucometer in your practice that you can just check the blood glucose. So, yeah, the big message here then is that practitioners need to be prepared for these situations. It can be disastrous if something like this does happen in your practice and you have got no emergency numbers, you've got no equipment. It's going to be an absolute disaster, and it will definitely not look good in your practice if something like this does occur. So how must dentists prepare themselves to be able to manage these situations? Good thing is to get yourself skilled up. It's a good idea to go for basic life support courses. They're not difficult to get into, and to have your emergency number available. Make sure it's at the telephone. If something like this occurs, the receptionist knows which numbers to call. It's up on a file. It's easy to get to, and make sure you are kitted out with an emergency kit that can handle these situations. But before we start getting into the emergency trolley and everything you need to be able to manage emergency situations, good thing is before that patient walks in for their procedure, that you already know the patient. You have a very good idea about the medical history. The patient filled in a medical history form. You know you're treating a diabetic. You know you're treating an epileptic. You know you're treating someone with an anxiety disorder, for example. Last week, I had a patient that had a very, very severe panic attack in my rooms, and we managed to monitor him and get him better. But if I didn't know this individual suffered from anxiety disorder before we started the procedure, he may have just as easily had some other problem. So it's always a good idea just to have all patients fill in the medical history form. It's absolutely invaluable. It aids with diagnosing. It sets your mind at ease. So step one, know your patient. And then this I got from the American Dental Association's journal. This is just a checklist that all practices should have. Make sure your staff members have specific duties. Something like this happens. Staff member X goes and fetches the emergency trolley. Staff member Y goes and informs the receptionist on who to phone. So yeah, everyone must just have their own duties, and make sure that some of your staff has an idea of what basic life support entails, and make sure that you are adequately equipped, and that you can even run drills at your practice. The American Dental Association recommends quarterly drills, and make sure that telephone numbers are available and make sure they work. Make sure your oxygen tanks are full and that they are checked regularly, and that none of your equipment in your emergency trolley has expired. So yeah, the emergency trolley. This is what everyone should aspire to having in their rooms, is an emergency trolley. They come in various shapes and sizes. Just this morning, I had a look at Grootte Schuur's emergency trolley, and I had a look what was in the trolley, and the drugs that I'm about to go through is what's in the emergency trolley. I'll just mention a few other ones that wasn't in the trolley, but that's not that important. So, okay, let's get going. Good idea to have your monitoring equipment available. Yes, it's probably a better idea before you start any procedure just to have a blood pressure cuff on and a pulse oximeter on. Any procedure I do in the rooms, whether it's just to pull a tooth, the patient has a BP cuff on and the patient has a saturation monitor on. If anything goes wrong, you can see, shoo, this patient's blood pressure dropped significantly all of a sudden. Then you can react to it to try and get it better. If you do the treatment, then you see, shoo, this patient's saturations are coming up. Things are improving. My treatment is working. So to have good monitoring equipment in your surgery, I think is invaluable. With that anxiety attack I had last week, I mean, his blood pressure dropped to 70/30. His saturations went down to 80, and we just calmed him down and gave him something to help him relax. and you could immediately see, oh yes, we put him in a feet elevated position, and you could immediately just watch the saturations improve, watch the blood pressure improve. And if you can see that, then already your mind's much more at ease. Yes, so going through the drugs that you need for emergency situations. This is the #1 drug. It's good for COVID as well. It helps the people with the COVID. It's oxygen. Oxygen comes in a cylinder, and if you want to know if it's oxygen, you can see it's got the white top there at the top. And then you also need a delivery system to give the oxygen. That middle one is called a Venturi mask. It works through the Venturi effect, which you can read up on it. It's a physics thing where if the velocity of gas flow changes, the pressure of the gas changes, and then if the oxygen goes through that narrowing, it's the velocity of travel changes and the pressure of the gas changes, and it sucks some air in from the side, and then it delivers oxygen at a certain percentage. And then the one you all probably know is the ambu bag there on the right-hand side. This is more for assisted ventilation, but you can also give oxygen to a patient by just holding it over the patient's mouth. Yeah, next slide. Also, it's a good idea to have some intravenous cannulas there. All the various sizes according to the colors. That's obviously the different gauge sizes. So for a child, you'd go smaller. For a bigger person, you'd go bigger. It's always a good idea to have all the sizes there just in case you need to get a drip up in an emergency situation. Usually start as big as you can, but if you can't come right, it's better to go smaller. If you have a very obese person, finding a vein can be a nightmare. So it's always a good idea to have all the sizes available. Let's go next slide. Then, besides oxygen, adrenaline is also a very good drug to have because it just covers and helps you in so many emergency situations. I mean, on the extreme, a patient with septic shock, you'd start an adrenaline infusion for them to support the vascular system. I mean, adrenaline has positive inotropic effects, it has positive chronotropic effects, but adrenaline is also invaluable at helping with anaphylactic reactions, allergic reactions. It can even be used for severe bronchospasm. In pediatrics, you can give it as a nib to a small child that suddenly has a bronchospasm. So here you can see the ampule there. It's a 1 milliliter ampule, 1 milligram at a concentration of 1 to 1,000. 1 to 1,000 is a bit much for giving it intravenously. So usually if you're going to give it intravenously, you have to dilute it to 1 to 10,000. So it's 1 mil with 9 mils of saline, 1 to 10,000 for IV use then if you want to give it for anaphylaxis. But usually in an anaphylaxis situation, you can give it intramuscularly as well. So then it's just half of the ampule. So if it's 1 milligram, that's half a milligram if you give half of the ampule. Yeah. So this is something you all should have seen before. This is the resuscitation algorithm. I put it in here just to show again there on the right, advanced considerations, adrenaline that you can give. And then it's the 3 H's and the compressions, the breaths, and then you've got if you have an AED available, then and the patient has the right type of rhythm, then you can deliver a shock. So I'm not going to go through this. I'm sure you've learned this. You can just learn this as any BLS course. The main idea of the talk is just to make you aware of how all of this fits into each other. This is just then the AED that should also be on the emergency trolley. I had a look at what they cost. The cheapest AED is just under 30,000. And if you want to be very fancy, they can go up to 200,000 Rand. So this is just to deliver a shock, but it's mostly in ventricular fibrillation and then ventricular tachycardia that you will defibrillate. Cardioversion is something completely different. That's just for certain types of arrhythmias, but that'll be more for the advanced. The simple AED is not a defibrillator. So you would just put this forms part of your resuscitation. Moving on, here's another slide. This is the treatment of anaphylaxis. This I just put in to show you guys all the things I've spoken about thus far. Is the oxygen. The patient gets a reaction to your lignocaine or to your bonding material. And then you give your oxygen and you can give your adrenaline. And here it says adrenaline 1 to 1,000, half a ml intramuscularly. And usually they recommend on the anterior lateral thigh, you can give it. And then the adjuncts to this treatment would then be an antihistamine and just to top it off then with some hydrocortisone that usually comes in 100 milligram ampules. This is also a good drug to have on your trolley, the benzodiazepines, which helps for anxiety as well, but it also helps for seizure disorders. This is your initial line of treatment for any person that's starting to seize. I've got an algorithm here that we'll go through a bit later. Even if you're treating someone that's an alcoholic that's having withdrawal from the alcohol, and you know from the medical history this is a person with an alcoholic problem, you can also give benzodiazepine then to help if you ever encounter a patient like that. Over the years at Tygerberg and Grootte, we have had patients with alcohol withdrawal that we had to manage. And here is just to show the algorithm again for seizures. There you can just have a quick look at it. And there you can see if your seizures don't stop, you can give your benzodiazepines, your intramuscular midazolam or intravenous lorazepam, and then that's the rest of the you can give a loading dose after the seizures have stopped. We usually give phenytoin then just to make sure the patient doesn't have another seizure, but just make sure you know the dosages. To give a benzodiazepine in an overdose can cause respiratory depression. So you must just be very sure that you're not giving too much if you are stopping a seizure. I put this in. I don't know how many people know the McGill's forceps. This is what anesthesiologists use when they put your throat back in. Any aspiration, anything back there in the oropharynx, this is your savior before it ends up in the bronchus. I've seen the odd root canal file in a bronchus. It's never nice then to tell the patient they have to go for a bronchoscopy. Perhaps there's still time and you can get your McGill's forceps and you'll be able to just fish it out before it's too late. Then going on to treatment of angina, myocardial infarction. Also a good idea to have some aspirin in your emergency trolley. I saw the Disprins, the aspirins in the Grootte trolley. It's there. You give the patient 300 milligrams of aspirin. They usually chew it and they swallow it. And you give sublingual nitrates as quickly as possible. The aspirin obviously helps to stop with the propagation of the clot, and then the nitrates is vasodilatory. Just make sure your patient is not on sildenafil. For those of you that don't know what sildenafil is, there's always Google. Just make sure they're not on anything that pushes their blood pressure too low, so that we don't give the patient a severe hypertension that will kill him before he gets to the cardiologist. Then I added this, also a good one, more for allergic reactions. Here it has a more immunosuppressive role, just to have some steroids. There's a lot of different steroids. This one is hydrocortisone. You can use dexamethasone, which has been in the news lately for the treatment of COVID. I like dexamethasone, but I use it more for post-operative swelling. Hydrocortisone is a good one to use for any allergic reaction. Right, then just some other drugs. Here you have your relievers for asthma. Here's your antihistamines, lots of antihistamines, first generation, second, third generations. Just take your pick. They all work. Some just have more side effects than others. Yeah, and then in case you're trying to stop your seizure and you gave a bit too much of the benzos, there's always flumazenol, which reverses the effects of benzodiazepines. I've never had to use it because I've never given too much. And then now we've gone through the emergency trolley of what needs to be on the emergency trolley. Now we are going to have a look and see what dentists actually have available in their surgeries. If you have oxygen problem, about a third of dentists will be able to help you with oxygen. Don't get a heart attack, because it seems like 8% of dentists have AEDs. It is an expensive thing to have. So, you know, perhaps a group practice can get one together. Suction, portable suctions. Not a lot of people have portable suctions, and oxygen cylinders. BP, half of people can take your blood pressure. So that's not too bad. Let's go on to the drugs. Half of people have adrenaline. I didn't expect that. And a quarter of dentists can stop your seizures for you. Glucose is also readily available. Again, don't get a heart attack. Nitrates are not that common. Midazolam, about 20%. Oxygen, salbutamol. So it seems like not a lot of surgeries are stocked with emergency trolleys, it seems. Okay, let's go just through a little sort of algorithm in case you do now have an emergency coming your way. There's, as you know, in HLS, it's the ABCs, then it changed to the CABs. So in your dental office, the algorithm is PCABD. So the P stands for, let me just take this away. P is for positioning, C is for circulation, A is for airway, B is for breathing, and then D is for definitive care. So I'll be going through each one of them and just saying what they are and how you should do it. Okay. Oh, it doesn't want to go. Oh, here we go. So positioning. If the patient is conscious, there's no point in, if they've aspirated or they're having a tight chest, there's no point in having to reposition and putting them flat on their backs if they're busy choking. So conscious patient, you will leave them alone. Unconscious patient, you would put supine with feet elevated slightly. Then circulation, this is just a pulse check, a 10-second pulse check where you check the carotid. If pulse is present, you go over to A, airway. If it's not present, you start your chest compressions. you climb on the patient's chest and you do proper chest compressions. The role of chest compressions is then to stimulate the contraction of the heart. If you feel no pulse, there's no heart contraction. Airway kills quickly. Patent airway is very important. Patient speaking to you, talking to you, has no problem with their airways. You don't need to check it, but patient that's not talking to you, you've got to open up the airway. Classic maneuver being then the head tilt, chin lift maneuver. You can also put in a artificial airway just to keep the airway open, depending on what you have available. Breathing, if patients are not breathing, obviously you have to support the breathing. This is where the ambu bag comes in. And then moving on to D, which is probably more what's going to be handled in the dental setting. Usually it's P, patient is unconscious, you position them, and usually they have a pulse, usually they are breathing, but now you have to go over to D. So definitive care being diagnosing, what is the problem? Do I need to give drugs? Do I need to get a defibrillator? Drugs being things like nitroglycerine, bronchodilators, aspirin, or oxygen. And this is then your life-saving treatment if needed. So in conclusion, preparation in these settings are key. It's always important to be prepared. Make sure you are adequately trained, you've gone through your courses, preferably on an annual basis, and take your team along. Make sure they know what to do and their development, that there's a clear plan in every surgery to be able to handle a medical emergency, and that you have the right equipment available. Okay, thank you very much.
Thank you very much, Dr. Barnard. That was definitely very informative, and we really appreciate your time. There's definitely been a few questions that if we can just run through that quickly, if you can maybe just answer that for us. So there's a few questions from the floor. What local can be used if allergic to lignocaine?
Yes, good local to use. The one, look, it's the amides and the esters. You can go over to an ester. I don't know how much they are available anymore, but a good alternative is to use bupivacaine. That's the only one that doesn't have cross-reactivity, is to use bupivacaine.
All right. I think just to add on to that, the comment also states that there's some patients that are highly allergic to sulfur-based preservatives, and it's not always listed. So you can give a patient an injection and send them into an anaphylaxis and not realize that it's a preservative. So is it important as a medical history to be informed of that?
Yes, no, it's definitely important to be informed about that. I'm not exactly sure how the sulfur preservatives vary from local anesthetic to local anesthetic. It's perhaps something also to look into. Yeah.
All right. There's also a question, is there any basic life support courses that you will recommend?
Yes, it's the BLS course is a good one to go to. Basic life support, it's the South African Research Council. You can just go onto their website. I'm not sure now in COVID times how easy it is to get to one of these courses, but yeah, you can just go South African Resuscitation Council. They have courses running all the time, and anyone can go.
Great, thank you very much. Another question here is, they ask, do you think it's prudent for dentists not to practice in isolation, but to be in the same premises with a medical doctor, particularly when a medical emergency arises?
Well, I think from this talk, most dentists should be able to manage a lot of these problems. Any GP is going to do exactly what I have said now. Any GP can, if the patient has hypoglycemia, you give sugar water. If the patient has a heart attack, you give, it's on your emergency trolley. And that patient, the GP is not a cardiologist. It's the same thing. The patient also has to be transported to an emergency unit where cardiologists are available. So I don't think dentists should underestimate themselves. They should be able to handle a lot of these things.
Great. Another question here is, would an oxygenator suffice instead of an oxygen cylinder?
Sure, that I do not know. Oxygenator. What percentage oxygen does an oxygenator deliver? It has to be pure oxygen, so it's 100% oxygen that's in a cylinder. I'm not exactly sure what an oxygenator. Perhaps I could Google it, but I don't know. Perhaps they could tell me.
All right, I'm sure they will elaborate a little bit more there if they want someone to ask that question. Then the next question is a little bit a different one, but I'm going to ask it in itself. It asks, could the doctor please give his opinion on the use of a whiff of cannabis as a calming remedy before dental procedures? It is widely available in South Africa, cheap and easy to administer, and likely to be made legal soon.
Yes, that's a very good question, actually, because you see, I myself am not a cannabis user. I have read that it has anxiolytic effects and it calms you down. But I think if we go on Google Scholar and if we Google this question, I'm not sure how many studies will be available to answer this question. So the person that asked the question, it's a very good idea perhaps to start a study like that, because since I've never used cannabis in my life, I honestly cannot say how it's going to remove any anxiety or anything. Perhaps if they can get ethical clearance for a study like that, it can be very useful and it can do wonders for dental practice. I think a lot more people will come to the dentist if they can get cannabis.
Possibly. Another question here is from someone that says, I work in government facilities where there isn't any of the emergency equipment available. I've requested the above, but it has not been provided. How do I go about acquiring all the medical emergency equipment? I think you've been working in government also for quite a while, so maybe you can just elaborate a little bit on that.
Yes, I mean, all our emergency trolleys are fully equipped. It's government's responsibility to have an emergency trolley, and if there is an emergency and you requested it, it's not you are not liable if you have requested it. So you must just document that you have requested it. To be able to get it, I mean, I don't think they're going to allow you to buy things out of your own pocket. It's their responsibility. You're going to have to find out who's in charge of purchasing at your hospital, go speak to them and see if you can get an emergency trolley set up for you.
Another question here is, all these injectable solutions needs proper training for the dentist to inject them. Should there be like courses for dentists to know exactly how to inject that?
Well, you'll be surprised that it's not that difficult to inject. Dentists are allowed to give, if you go into HPCSA, they are allowed to give blood transfusions. It's not that difficult. It's just a case of getting the confidence. Perhaps a good idea would be to do a postgraduate diploma in maxillofacial surgery. I have diploma students coming to me and they learn a lot about giving IV drugs, putting up drips. So it's perhaps something to think about if you don't feel confident about it, just coming to the university and entering for a diploma program, most likely in MaxFac then.
Yeah, thank you. Next question, will it benefit a patient to give a glucose solution following a vasovagal syncope?
Well, vasovagal syncope, well, they've been sympathetic, they've been very anxious, so they might have low glucose. So yeah, it can't hurt. You don't know what their glucose is, so it really can't hurt. Just giving someone some sugar water can't do any harm, because they may have been very anxious for a long time and they may have a low glucose, you don't know. So there's no harm in it.
Great, just a comment. So we have some comments from the floor here. Someone just commented regarding the oxygenator can provide oxygen at 96%, and there's also electric oxygen generators, concentrators available that can provide 100% oxygen. Any case, all right. Training in the ER. This is important. Pharmacy students are being trained in the ER. Why not dental students?
It's not a bad idea. It's something that can be addressed. I mean, dental students, they rotate through a bit of general surgery, they rotate through a bit of internal medicine. There's no reason why they can't. Paramedics spend time in casualties. It's perhaps something that can be looked at. Yes.
I do agree. Just the last question here, maybe from the floor. It just says, could you kindly give a list of most common emergencies and what drugs to give, the dosages and the mode of delivery? I do think that you touched on that already. So.
Yes, I've touched on it. You see, you get so many different steroids that each one has a different dose. You get so many antihistamines, each one has a different dose. It's just a case of getting the pamphlet and reading the pamphlet, and it's as simple as that. Anyone can look it up. Yeah.
Great, thank you for that. I do not see any further questions from the panel. So with that, I think we will draw to the close. Thank you very much. Please remember to fill in the polls that is available on your screen. And then I will also give over to Dr. Asmal. Thank you.
Yeah, just a quick thank you from all of us, from our Algoa Midlands branch, and to everybody that's attending this webinar. Dr. Barnard, it was a very informative webinar, and I can foresee that Dis-Chem and all our medical suppliers are going to be inundated with phone calls from all the dentists needing to stock up their emergency trolleys. Thank you very much for all the information, and well done as well. You can breathe now, you can relax. It's all done. You got through that. But thank you so much again, and I hope everybody did enjoy. Please, once the webinar does end, there will be an evaluation form that will come up for you to please just fill in for us so we can collect all of that data. But thank you so much for your time this evening, and please go and enjoy your own snacks in your kitchen. Unfortunately, SADA won't be providing this evening. Thank you very much. Good night, everybody.
Thank you, everybody. Thank you, Dr. Barnard. I'll go Midlands branch. I'm going to close this meeting now. Good night, everybody.
Good night. Thanks.